Respiratory volumes are what we use to assess the status of your respiratory system. So essentially, how well are you breathing in and breathing out? Are your lungs holding enough oxygen? Are you able to blow out enough CO2? That's what these respiratory volumes are. So we actually have four different respiratory volumes. The first one is called tidal volume. Sometimes for short, it's TV. This is the air that is just moving into and out of your lungs during normal, quiet breathing. So, what is quiet breathing? This is basically if you're just sitting, you're not exerting yourself, you're not exercising, you're not heavily breathing, it's just normal, quiet breathing. I remember this because I think of the tide coming in and out. And so I think of a tidal volume as just the natural air movement in and out of your lungs. This is around 500 mils. Now the second one is called the inspiratory reserve. So pay attention to the first word, inspiratory. This is the amount of air that you can inhale with maximum effort after your tidal volume inhalation. So if you're sitting watching this, I want you to just do a normal breath in and out. And on your next normal breath in, keep breathing in. Keep going. Breathe in as much as you can. Fill your lungs up to their fullest. That's the inspiratory reserve. This can be anywhere from 2,100 to 3,200 mils. It just depends on the person. Males usually have a slightly higher inspiratory reserve. Also, athletes, people who are well conditioned, can have a higher inspiratory reserve. If you're doing a lot of cardiovascular activity, that can really help to increase your inspiratory reserve. Now, the third one here, the expiratory reserve, is sort of the opposite of the inspiratory reserve. Again, think of this word expiratory. So this is the amount of air that can be exhaled with maximum effort after tidal volume. Again, these are both after your normal breath in, normal breath out. So again, if you're sitting, I just want you to take a breath in, normal tidal volume, take a breath out, take a breath in, and after your normal breath out, keep blowing that air out. Keep blowing out CO2. Keep going until you get to the point where you feel like there is nothing else that can come out. That's your expiratory reserve volume. It is the amount of air that you can exhale with maximum effort after tidal volume. This is anywhere from 1,000 to 1,200 mils. And then lastly is something called residual volume. So residual volume is the air that stays in your lungs even after your expiratory reserve. So even after you have blown out all of the CO2 that you can blow out, you feel like your lungs are going to collapse. You can't blow out anymore. There is still air left in your respiratory system. There is still air left in your lungs. That's the residual volume. There has to be air left to keep your alveoli open. If you blew out all of the air, your alveoli would collapse, your lungs would collapse, and that would be horrible. So residual volume just holds the alveoli open. This is not actually exchangeable air. So the air that's called our residual volume is left in the lungs. It's not actually air that's ever leaving. It just stays in there to hold everything open. So when we look at this, at these four different respiratory volumes, it's only 1, 2, and 3, tidal volume, inspiratory reserve, and expiratory reserve, that are considered exchangeable air. The last one, residual volume, stays in the lungs to hold them open. So now what we're going to do is we're going to use these respiratory volumes, these four volumes, and we're going to use these to assess respiratory capacities. So this is a combination of these volumes. So one type of capacity is something called vital capacity. Okay, vital capacity is the total amount of exchangeable air, right? So this would be our tidal volume, normal breath in and out, inspiratory reserve, big breath in, and expiratory reserve, big breath out. Okay, so if we go back, that is all of these right here. These first three, again, this is essentially the exchangeable air. Okay, so that is what's called our vital capacity. The second one is our total lung capacity, and this is all four of those respiratory volumes. So it is the sum of all of those volumes. So it includes even, let's go back, this bottom one down here, our residual volume. Okay, so it's all of these combined as our vital capacity. And the vital capacity for a healthy individual is around 6,000 mils. Again, it varies from person to person. Usually there's a difference between males and females. There's also usually a difference between someone who is incredibly athletic. Their volumes will be higher. Now this is taking our respiratory volumes. Okay, so we can see those right here. It is taking those respiratory volumes and putting them on a graph so we can actually look at them and we can look at the change. So you can see we have mils here off to the side, milliliters. And so we can see in this light blue right in the middle, remember this is our tidal volume, it's about 500 mils. This is a normal breath in and out. So you can see here if we follow the graph, normal in and out. We're going to skip over. Normal in and out, in and out. That's our tidal volume. At the top, you can see this is our inspiratory reserve. This is the extra we can breathe in after tidal volume. So we can see this is our inspiratory reserve. Big breath in until you feel like you can't breathe in anymore. We also have an expiratory reserve, how much extra we can exhale after our normal tidal volume. So that's this darker blue here, expiratory reserve. And then at the very bottom, notice that this graph doesn't actually make it, this line never makes it down into the green, because remember this is not exchangeable air. Our residual volume is what is left in the lungs to hold the lungs open. It's not exchangeable. Okay. So now we can look at our respiratory capacities. Remember we have two capacities, vital capacity, which is all of the exchangeable air, okay, inspiratory reserve, tidal volume, and expiratory reserve. And then our total lung capacity, which is everything, all four of those respiratory volumes. Okay, so this is the same thing, just in a graph form. So we call this graph a spirographic record. So let's talk a little bit about what a spirographic record is and how do we measure these respiratory volumes and capacities. So how we do this is we use something called a spirometer. A spirometer is a little instrument that can measure your respiratory volume. Spirometers can be incredibly sensitive. They can be hooked up to computers. They can be very accurate, very precise. We also have some handheld spirometers. This is what we use in the face-to-face anatomy class. These are definitely less accurate than the ones hooked up to computers, but they can give you a general assessment of your respiratory volumes. So we have different kinds of spirometers, but that's the instrument that is used to assess those volumes. And the great thing about a spirometer is that it can actually distinguish between whether someone has an obstructive pulmonary disease. Okay, so an obstructive pulmonary disease, think of the word obstructive. You have an obstruction. That means there is resistance getting the air into the lungs. Okay, so there's an increase in airway resistance. And what ends up happening is you try to circumvent that resistance and you take bigger breaths in and your lungs hyperinflate. Okay, so a lot of times what we'll see, think of someone who has, bronchitis, for example. A lot of times when you have bronchitis, you're taking these big breaths in because you're trying to overcome this resistance. So the lungs are hyperinflating. They're inflating more than they should, right? You're breathing in more than a normal tidal volume. So we see your tidal volume go up. So someone who has a high tidal volume might have an obstructive pulmonary disease. We can also use a spirometer to assess restrictive disorders. So this is where, think of the word restrictive. Okay? It's preventing the lungs from expanding. It's restricting them. It's holding them in. And so if you cannot expand the lungs, your tidal volume is going to go down. So based on your just normal tidal volume, a spirometer can assess, oh, this person has an obstructive disease, they have bronchitis, or they have asthma. Or this person has a restrictive disorder. Maybe the individual has scoliosis and it has caused deformities in the rib cage and the lung cannot expand. So their tidal volume is lower. Okay, maybe they have sunken chest. Their lungs cannot expand, so their tidal volume is lower. So based on these spirometer numbers, based on these respiratory volumes that we get from using a spirometer, we can see whether someone has an obstructive disease or they have a restrictive disease. Now, there are some non-respiratory air movements that we see in individuals. So these a lot of times can alter the rhythm of a normal tidal volume. And so a lot of times these are reflexes. So like, for example, a cough or a sneeze, yawning. We don't actually know why people yawn. But when I talk about yawning or when I see someone yawn, it makes me want to yawn. So a lot of these are reflexes, but some are voluntary, obviously, like laughing. I don't know if I would say crying is voluntary. I guess it is. Hiccups, those are reflexes. So these are all things that are going to alter your normal respiratory rhythm. And a lot of these things actually help to promote the movement of blood and lymph. And so with yawning, for example, a lot of times you'll yawn when you're tired, and yawning really can help to increase blood flow to the brain to help you wake up a little bit. Again, that doesn't really account for why when I talk about yawns or you see someone yawn, you want to do it, but yawns are pretty interesting. Now, there is one slide I missed, so let's skip on back here. I do want to just touch on the dead space. So, anatomical dead space, this is something that does not actually contribute to gas exchange. So this would be anytime air is left in your conducting zone structures. So anywhere from the nasal cavity all the way down through the trachea, the bronchi, the bronchioles. If the air is not in the alveoli, there is no gas exchange happening, right? The only place gas exchange happens is in the alveoli. Everywhere else, it's considered anatomical dead space. And the amount of air that will remain in all those passageways that don't contribute to gas exchange is about 150 mils. Now, we also have something called alveolar dead space. Now, this is very different. Normally, alveoli contribute to gas exchange, but sometimes you have non-functional alveoli that are not functioning because they are obstructed or because they have collapsed. So a great example that I have down here, this image at the bottom, these are normal alveoli. They look like a bunch of grapes, but you can see the image below that. This is alveoli with emphysema. So emphysema is a disease that causes the walls of the alveoli to break down. So instead of having a bunch of grapes, you basically have this one big sac. So you have decreased the surface area tremendously, so the amount of gas exchange will also be decreased tremendously. So someone with emphysema, because they don't have the surface area for gas exchange, they really cannot get enough oxygen. So they are constantly struggling for breath. They take big, deep breaths in and blow out. So let's talk a little bit about what we talked about with the spirometer. So a lot of times when someone has emphysema, their tidal volume will increase. So what's happening is they're taking these big breaths because the gas exchange isn't happening. And so they're taking these big breaths that's just not very helpful. So the tidal volume has gone up. People with emphysema a lot of times will have a condition called barrel chest. because they struggle to breathe and they breathe so frequently and so fast. They're using a lot of extra accessory muscles to breathe in. So not just their diaphragm, but they're using their intercostal muscles, their scalenes. They're using a lot of chest muscles to help increase that thoracic cavity and get a good breath. And so this causes a change in the shape of their chest, and they get this what's called barrel chest shape.